The patient position and ultrasound approaches. One starts the scanning of the carotid arteries with the patient in the supine position with their neck a little extended by placing a pillow under their shoulders. The patient's head should be turned 45 degrees to the side, facing away from the arteries under investigation. The patient should be comfortable, avoiding any excessive extension of the neck. He or she will be lying in this position without moving for an extended period of time. Usually, the examiner sits beside the patient's thorax and scans the neck from this position. Some patients may not be able to lie supine. In such cases, they can usually be examined just as effectively in the sitting position. It should be noted that investigating the patient while he or she is sitting will be uncomfortable for the examiner, who must scan the arteries while standing up or with his or her arms lifted in the air. One may use 3 approaches to carotid arteries: anterior, lateral, and posterior. With the anterior approach, the position of the transducer is medial from the sternocleidomastoid muscle. With the lateral approach, the position of the transducer is directly on the sternocleidomastoid muscle. With the posterior approach, the position of the transducer is behind the sternocleidomastoid muscle. Identifying the course of the carotid arteries. The first step of the investigation is to identify the course of the carotid arteries. One starts the investigation with the posterior longitudinal approach. Usually, a microconvex transducer with a frequency of 3 to 5 MHz is used. One can substitute a microconvex transducer with a convex or sector transducer set at the same frequency. In this film, a sector transducer set at a frequency of 3.3 MHz is being used. These approaches and parameters of the transducer allow us to obtain images of the proximal part of the common carotid artery of bifurcation of the internal and external carotid arteries. We are also able to completely visualize the course of the internal carotid artery to the point where it enters the skull. In addition, one can visualize the place of origin of the right and especially of the left common carotid artery. In most cases, this visualization is not possible with the linear transducer. To investigate the course of the vessels, one should activate the color Doppler. Normally, the carotid arteries have a direct course. If one sees this kind of course of the arteries, one should note in the protocol that the course is normal. When one uses a sector or microconvex transducer set at a frequency of 3 to 5 MHz, one intentionally sacrifices the quality of the two-dimensional image in order to obtain a more complete picture of the course of the arteries. Usually, one can visualize the small convexity of the internal carotid artery. If the course of arteries is deviated, one should note in the protocol the type of deviation. S-type or tortuosity, coiling, and kinking. In the last case, one sees the artery bending at an acute angle. The deviation of the artery can cause disturbances of the blood flow, which are local in most cases. When using the spectral Doppler, one should take peak systolic velocity measurements in the places of the artery where turbulent flows are registered. When using the spectral Doppler, one should listen carefully to the audio signal in order to note possible spectral broadening caused by turbulence. In the case of mild fibromuscular dysplasia of the internal carotid artery, the only symptom will be the spectral broadening. Identifying the internal and external carotid arteries. For beginners, it may be difficult to identify the internal and external carotid arteries. So let's talk about some useful tips which could help make identification of these arteries a bit easier. The common carotid artery on the right rises from the innominate artery behind the right sternoclavicular joint, where its origin can usually be seen on ultrasound. On the left, it usually arises directly from the aorta, so that its origin on the left cannot be seen on scanning from the neck by linear transducer. However, the sector or microconvex transducer will usually make it possible to see the origin of the left common carotid artery. The level of the carotid bifurcation is usually at about the level of the upper border of the laryngeal cartilage, but it may vary considerably. The two branches of the common carotid artery are the internal carotid artery and the external carotid artery. It is essential that they are identified positively. Otherwise, there is the possibility that disease in one vessel will be mistakenly attributed to the other, which may lead to further inappropriate investigations. The external carotid artery is usually the easier of the two branches at the bifurcation to recognize positively. The external carotid artery is nearly always the more anterior of the two branches. The external carotid artery has branches which arise from it below or around the level of the angle of the mandible. The external carotid artery supplies the relatively high resistance vascular bed of the facial muscles, pharynx, tongue, and scalp. Therefore, the external carotid artery has relatively less diastolic flow, which makes it appear more pulsatile on color Doppler and to have a characteristic waveform on spectral Doppler with relatively low diastolic flow. In addition, the dicrotic notch of the pulse wave is usually more prominent in the external carotid artery spectrum than in the internal carotid artery spectrum. The superficial temporal artery is one of the terminal branches of the external carotid artery, and if this is tapped by a finger as it passes over the zygoma, it will produce rapid, clear fluctuations in the waveform of the ipsilateral external carotid artery. However, if one performs Doppler investigation of the ipsilateral internal carotid artery or the common carotid artery, this tapping will produce little or no result. Once the external carotid artery has been identified positively, It can be assumed that the other large vessel arising from the carotid bifurcation is the internal carotid artery. This vessel is nearly always the more posterior of the two branches and tends to run deeply. It does not have visible branches at this level. In addition, the diameter of the internal carotid artery is usually larger. In subjects without severe disease, the carotid bulb is usually apparent and one can see its pulsations. Color Doppler will show the normal area of reversed flow in the carotid bulb, sometimes referred to as the boundary layer separation zone. The spectrum from the internal carotid artery is less pulsatile and more sustained than that of the external carotid artery. The internal carotid artery has relatively high diastolic flow. The internal and external carotid arteries also have different audio signals. The audio signal from the internal carotid artery is softer and more wispy compared to the signal from the external carotid artery. In most cases, one can differentiate the internal and external carotid arteries during the first stage of scanning by using the sector or microconvex transducer for identifying the course of the vessels. Next, one should visualize the extracranial part of the vertebral artery and pay particular attention to its proximal part before it enters the vertebral canal, since this part of the artery cannot usually be visualized with the linear transducer. After one has identified the course of vessels on one side of the neck, the same procedure must be performed on the other side. Identifying Doppler parameters of blood flow. After identifying the course of the carotid and vertebral arteries with the help of a microconvex or sector transducer, one should use a linear high-frequency transducer for detailed investigation of the arterial walls and identification of Doppler parameters of blood flow. The frequency of the transducer should be between 7 and 12 MHz. The examination starts from the anterior approach. One performs a transverse scan of the carotid artery by moving the transducer from the lowest part of the neck to the highest part, behind the angle of the mandible. This approach will allow the depth and course of the vessels to be ascertained, together with the level of the bifurcation and the orientation of its branches. In addition, areas of major diseases will be identified and can be noted for further assessment. Color Doppler is then activated and the vessels are examined in the longitudinal plane, again from the lower neck upwards. With the help of color Doppler, one can identify areas of abnormal flow. One can then make an initial assessment of their significance and determine whether further spectral examination is necessary. It is also important to note that one can see areas of normal flow, and one can also take the peak velocity measurement in normal segments of the common carotid artery. This velocity will serve as the standard for comparison with spectrums taken from diseased segments. It may be necessary to try a variety of scan planes in order to see the bifurcation in some patients. One should use all three mentioned approaches. Anterior approach. Lateral approach. The posterior approach, which in most cases allows one to obtain the bifurcation and the origin of the internal and external carotid arteries on the same image. If necessary, one can take for the protocol the peak velocity measurements in common carotid artery, internal and external carotid arteries. For routine measurements, the sample volume is set at about 1/3 of the total diameter and placed in the center of the vessel. There is natural turbulence at the edge of the lumen and so-called wall thump. One should also make correction of the Doppler angle. The Doppler angle is kept as low as possible, ideally less than 60 degrees. If the angle will be more than that, the measurements will not be correct. In this picture, one can see the places where the Doppler velocity measurements should be taken for the protocol. The velocity measurements are obtained using spectral Doppler from the upper common carotid artery 2 to 3 centimeters below the bifurcation. One could also take the velocity measurements on color Doppler image. One should register the Doppler spectrum in the internal carotid artery from 1 to 2 centimeters above the bulb, or as high as possible, in order to allow the normal bulbar turbulence to settle. This is so-called the boundary layer separation zone. One should also register the spectrum from the lower external carotid artery. Measuring the intima-medial thickness. If one has not revealed the atherosclerotic plaques in the carotid arteries, then one should measure the intima-medial thickness, or the IMT. This is an important parameter in assessing the state of arterial wall. The IMT should be measured on an image of the distal common carotid wall where the echoes from the intima media complex are most easily distinguished. The machine settings should be set to give a clear, uncluttered image of the vessel wall. The position of the transducer should be adjusted to show the characteristic double-line appearance of the vessel wall. The image should be magnified as much as possible to make the measurement easier to perform. Sometimes, for clear identification of the IMT complex, one uses the zoom function. The precise upper limit of the normal range is a matter of some discussion. The IMT does increase with age, but values of less than 0.8 millimeters correlate well with lack of coronary artery disease, whereas an increasing thickness above this level is associated with increasingly severe coronary artery disease and increased risk of myocardial infarction. It should be noted that IMT measurement less than 0.8 millimeters does not exclude the presence of atherosclerosis. It only indicates the lower risk of myocardial infarction. We have had many cases when the atherosclerotic plaque was seen on bifurcation, but the IMT measurements were in the normal range. After measuring the IMT, one should analyze the internal and external outline of the arteries. The cluttered external outline of the artery and edematous intima media complex can help in diagnosing aorta arteritis. On the other hand, the uneven internal outline could indicate atherosclerosis. One should also analyze the diameters of carotid arteries so as not to miss any possible aneurysms. In order to obtain a more accurate correlation between the ultrasound diameters and anatomical or surgical diameters, one should put calipers on the external outline of the artery. Vertebral arteries. Once both carotids have been examined, the vertebral arteries are assessed. The vertebral artery on each side is the first branch of the subclavian artery. It passes posteriorly and upwards to the vertebral foramen in the transverse process of the 6 cervical vertebra, and from there it passes upwards in the vertebral canal to the level of the axis. It emerges from the vertebral canal at the level of axis, passing behind the lateral mass of the atlas to enter the skull through the foramen magnum, and runs anterior to the brainstem to join with the vessel from the other side in front of the brainstem to form the basilar artery. The vertebral arteries are most easily located by placing the transducer longitudinally over the common carotid artery and angling it medially so that the vertebral bodies are identified. After that, the transducer is rotated laterally so that the transverse processes of the vertebrae and the spaces between them are visualized. One can see the vertebral artery and the vein in these gaps. One could also identify the vertebral artery in the lower neck as it passes backwards from the subclavian artery towards the 6 cervical vertebra. Another place where the vertebral artery can be visualized is in the upper neck behind the mastoid process as it passes around the atlas and into the foramen magnum. It is important to note that in this area, the vertebral artery makes a physiological deviation, which in the posterior approach could be erroneously interpreted as a pathologic deviation of the internal carotid artery. In this case, it helps to compress the common carotid artery with a free hand. If one visualizes the vertebral artery, the Doppler spectrum will stay constant or its amplitude may increase. If one visualizes the internal carotid artery, the Doppler spectrum will decrease or disappear completely. There may be marked variation in the size of the vertebral arteries. Their relative contribution to basilar artery flow also differs. When there is disparity of size, the left artery is usually the larger of the two. In 7 to 10% of individuals, there are significant segments of hypoplasia which result in the artery not being visible. When one can visualize the vein but not the artery, it suggests that the artery may be either thrombosed or congenitally absent. Color Doppler makes the assessment of flow direction in the vertebral arteries straightforward. They should have the same color as the common carotid artery in front of them. If one reveals the different colors in the carotid and vertebral arteries, then it could suggest the reversed flow in vertebral artery. This can also be the result of occlusion or tight stenosis of the proximal subclavian artery, so-called subclavian steal syndrome. In this film, we have demonstrated the approach to a routine investigation of the extracranial carotid and vertebral arteries. We have also demonstrated how to obtain all necessary dimensions for these arteries. Once one reveals the pathological course of the vessels, the anomalies in the arterial wall, and the increased diameter of the artery or pathological Doppler spectrum, the patient deserves a more detailed analysis, which will be the topic of our next films.